Good morning. I have the distinct pleasure of introducing a friend and dear colleague, Dr. Ndidi Unaka, who is our inaugural Chief Health Equity Officer at Stanford Medicine Children's Health and joined us in July 2024. Prior to her transition to our hospital, she was on faculty at Cincinnati Children's. She did her undergrad at University of Oregon and played basketball. Division I, and then went to University of Michigan, where she did her MD, and then moved to Cincinnati Children's, where she did her residency, completed a chief residency, and then joined the faculty, where she was an assistant program director for over a decade. In addition to her work in medical education, for which she received a Master's of Education in 2015, she was a key leader at Cincinnati Children's and a lot of their health equity and operations initiatives. Most notably, I wanted to point out that she was a faculty lead within the Cincinnati Children's Fisher Health Equity, Child Health Equity Center, and focusing and working on operations leaders to ensure that equity was embedded in all of their strategic plans and their goals and their metrics across all of their sites, so not just the inpatient sites, but all sites. And she also co-led the Cincinnati Children's Health Equity Network, which really was thinking about not just what was happening in the hospital at Cincinnati Children's, but thinking about how the hospital integrated into a larger community. I've known Dr. Unaka for over a decade, and I'm really excited to have her, to be able to work with her as a colleague and a friend, and I'll welcome her up. Thank you.
Thanks so much, Chris, for that introduction, and thank you all for making time to come this morning. I am really honored to be giving grand rounds this morning, and the title of my talk is From Insights to Impact, a Strategic Roadmap for Excellent and Equitable Health Outcomes. So the objectives of my talk are to articulate the need for an unrelenting pursuit of maternal and pediatric population health and health equity. I hope that you all are able to gain critical insights from PHHE research, and I will share several examples. And I hope to illustrate how generated evidence informs and enhances quality improvement initiatives. And finally, I hope that you all walk away appreciating the value of learning networks to share best practices, lessons learned, and innovative approaches to identify and narrow equity gaps. But before we go deep into this talk, I want to take some time to underscore the why population health and health equity is so important. And I'll do that by sharing several patient and family experiences. The first patient case is of an adolescent male who was diagnosed with type 1 diabetes and subsequently was the victim of a gunshot wound that necessitated amputation of his left lower extremity. Over the course of 8 years, he had multiple encounters with our healthcare system in Cincinnati, and many of those encounters were likely preventable. He had 13 admissions specifically for diabetic ketoacidosis, 25 admissions to the pediatric ICU, and 147 emergency department visits. The patient and his family have had multiple health-related social needs that certainly impact his health and well-being. And his struggles with type 1 diabetes and his exposure to violence certainly isn't isolated. We know from the literature that significant racial and ethnic disparities exist as it relates to type 1 diabetes control and outcomes. And we know that Black children and adults are disproportionately impacted by violence. The next case is of a mother who presented to the hospital in labor around 2 in the morning. Her baby was showing signs of distress, and the team quickly readied her for an emergency C-section using a Spanish phone interpreter, but she did not consent. Risk management and the legal department were called and approved the procedure, and the baby was safely delivered. Around that time, an in-person Spanish interpreter arrived, and after meeting with the parents in the recovery room, they let the team know that the parents spoke Mon, which is a Mayan language, and did not understand Spanish. Again, this family's experience is not isolated. We know that families battle managing language barriers across healthcare systems in the United States. And finally, this is a case of a patient that I cared for, a 15-month-old girl who was admitted to our hospital medicine service the evening prior with a presumptive diagnosis of acute gastroenteritis. She was persistently febrile, and while she had loose stools early in the course, she had no diarrhea for 2 days prior to admission. I remember being really worried about this patient the night prior. We obtained an ultrasound to rule out intussusception, and we consulted surgery. Surgery was not concerned about her abdominal exam and were adamant that appendicitis was not on the differential. We ordered a stat CT anyway, and her abdominal CT showed a perforated appendicitis. Again, this patient's clinical course is not isolated. We know from the literature that there are significant racial and ethnic disparities as it relates to the delayed diagnosis of appendicitis among children, with Black children being more likely to be diagnosed with perforated appendicitis and less likely to receive confirmatory imaging than their white counterparts. So here are the facts. Health inequities are ubiquitous among maternal and pediatric patient populations. Marginalized communities of color and poor children are disproportionately impacted, and racism and discrimination in all its forms are undeniable root causes. Many of you are very familiar with the term social determinants of health, which are the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. When we talk about social determinants of health, we're talking about 5 domains: education, access, and quality, healthcare and quality, neighborhood and built environment, social and community context, and economic stability. All of these domains are interconnected. In fact, where you live is probably the one domain that has influences on all of the other domains. We know that neighborhood characteristics are influenced by the legacy of redlining, and that place impacts access to quality education, quality healthcare, green space, public transportation options, well-stocked grocery stores, and other amenities. This is a figure from a national cross-sectional study that was looking at Child Opportunity Index and its association with life expectancy at birth. They found that lower opportunity was significantly associated with a stepwise decrease in life expectancy. And you can see the variation of both Child Opportunity Index and life expectancy across the United States. We also know that where you live influences your access to healthcare. This is an analysis of over 4,000 hospitals that was surveyed annually by the American Hospital Association that showed that less than half had pediatric units, with almost a 20% decrease from 2008 to 2018. This is another study published in JAMA. It was a cross-sectional analysis of over 23 million inpatient pediatric hospitalizations over a 10-year period. Birth hospitalizations decreased by nearly 11%, non-birth hospitalizations decreased by nearly 30%, and the largest decreases were noted at urban non-teaching hospitals and rural hospitals, most of which had less than 25 non-birth pediatric hospitalizations in 2019. So let's start and talk about a few other definitions. We can't really have a conversation about health equity without understanding population health, which is defined as the health outcomes of a group of individuals, including the distribution of such outcomes within the group. And health equity, as defined by the Robert Wood Johnson Foundation, is a state in which everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty and discrimination and their consequences, including powerlessness and a lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. Again, addressing the social determinants of health. So now I'm going to transition and highlight a population health and health equity roadmap that my colleagues and I conceptualized and was able to share in a publication. And I'm going to walk through this roadmap as it progresses from scientific building blocks to excellent and equitable health outcomes at scale. Each step of this roadmap is strengthened by patients, families, community partners, and frontline teams. And so the first step of this roadmap is P1, basic population health and health equity science. And this step in the roadmap is all about defining context and elevating critical questions. Basic PHHE scientists might map a city block or systematically review successful innovations in different fields. So here's an example of a study that would fall into this step of the roadmap. In this study, we sought to estimate two things: the total inequities in population health hospitalization rates, as well as determine how much of the hospitalization rate inequity was mediated by place-based exposures and community characteristics. We conducted a population-wide and neighborhood-level study of youth less than 18 years of age who were hospitalized between July 1st, 2016 through June 30th, 2022. We defined a causal-directed acyclic graph a priori to estimate mediating pathways by which marginalized population composition causes census tract level hospitalization rates. So this is our causal DAG, and just to talk a little bit about what a DAG is, it is merely a graphical representation that visually depicts causal relationships between variables, where the arrows indicate the direction of the causal effect, and the structure is designed to illustrate how one variable influences another without feedback loops. So if you look at this DAG, you see that it starts off with complex historical processes, otherwise known as institutional and structural racism. And that in and of itself influences your membership in a marginalized racial or ethnic group. It influences your family's socioeconomic status at birth. It also may influence residential neighborhood characteristics. And you can see how the variables move on and can influence likelihood of hospital admission. So we analyzed over 50,000 hospitalizations experienced by over 28,000 patients, and we were able to successfully geocode nearly 99% of all hospitalizations to a census tract. And we calculated all-cause census tract level hospitalization rates per 1,000 children, which ranged from 10.9 to 143 across all included census tracts. So this figure is showing several things. We were able to classify census tracts into high, medium, or low combinations of census tract level hospitalization rates and census tract material deprivation index. And as you can see on the scatter plot on the right, you can see the correlation between census tract level hospitalization rates and deprivation index, with higher rates of hospitalization being associated with higher deprivation in the neighborhoods. And then the map on the left just shows the spatial distribution of these census tract categories. The unadjusted analysis essentially showed that for every 10% increase in the marginalized racial or ethnic population, census tract level hospitalization rates increased by 6.2%. We then went back to our DAG, and our DAG indicated that to estimate the true effect of membership in a marginalized racial or ethnic group on pediatric hospitalization, we needed to block confounding by place-based exposures and community characteristics. When we did the adjusted analysis, we found some very interesting things. So to orient you to the figure on the right-hand side, on the x-axis, you have types of admissions, including all-cause admissions, admissions specifically for asthma, type 1 diabetes, sickle cell disease, as well as admissions for mental health disorders. The red circles indicate the unadjusted measure of inequity in hospitalization rates, and the blue triangles indicate the adjusted inequity in hospitalization rates. After we adjusted for place-based exposures and community characteristics for all-cause hospitalizations, no inequity remained. The results were different when we considered the different subsets of hospitalization types, as you can see on the chart. The next step in the roadmap is focused on efficacy. This is all about generating ideas, change concepts, and hypotheses that can subsequently be tested on a small scale in a controlled manner. And the study type that is best for this particular step in the roadmap are qualitative studies. Qualitative studies can be used to explore the experiences, perspectives, motivations of individuals with lived experience, to identify and tailor strategies that best address their needs and their challenges. We often are talking about social determinants of health, health-related social needs, social risk factors, and we can't really have that conversation without talking about the medical social continuum. We know that medical and social care approaches are often pursued in isolation from one another and in unbalanced ways, which may perpetuate inequitable health outcomes. And so we wanted to do a qualitative study to really understand and generate insights from and with patients and families and community members to design a better, more integrated medical social care system. So we partnered with 4 peer researchers. These are researchers from the community. They were not affiliated with our academic institution. And each of these peer researchers conducted at least 4 one-on-one virtual interviews with individuals of their choosing in either English or Spanish. Most participants identified as a minority race or ethnicity and lived within structurally disadvantaged Cincinnati neighborhoods. Interviews followed a co-designed question guide, which assessed beliefs and attitudes about how healthcare, human services, patients, families, and communities intersect when it comes to medical and social care. We identified several study themes and opportunity areas that affect medical and social care delivery, and I will walk through each of these themes next. So the first theme, medical and social services are difficult to navigate. Participants spent hours navigating cost systems, using transportation, and sitting in waiting rooms to get healthcare and social services. And there was a tension between time and energy necessary to navigate medical and social services and the potential benefits when these services were accessed. One participant said, "When you choose the option for Spanish, they leave you waiting until they find an interpreter. Sometimes I go with my niece who helps me make my appointments for me, but in English, because they help you quicker." Another participant said, "Do not send me to a community partner where the wait list is 2 years long, and you knew that before you gave me the information. I need real resources." Theme 2, medical and social care are often reactive or non-existent when they could be proactive. Participants repeatedly highlighted how current medical and social care systems rely on patients and clients to self-advocate and have existing knowledge of how systems operate. One participant noted, "I really appreciate it when someone says, 'I haven't seen you in a couple months. What happened? Is there anything you need? Is there anything preventing you from being able to come in and get the care you need before it gets to the point where you truly, truly need care?" And another participant said, "I've been running into a lot of resources that I didn't even know existed. I know there are other people that probably didn't know this exists." The third theme, medical and social care could be more closely integrated. Even when families know that certain medical and social resources exist, access feels often unattainable. Information about resources and services also are often poorly communicated or out of date. One participant said, "If I go to the hospital and I'm there, my child has an appointment, but I also need help with food or clothing. If I mention this, they can have someone come in and talk to us about that then." Another participant said, "I would be super excited to see social services organizations at the hospital, either just there to share information or trying to share their services they provide to people." Theme 4, medical and social service institutions are often untrustworthy. Families of color know from their lived experiences and the experiences of their friends and community members that medical and social institutions are often not safe spaces. One participant said, "If you had a negative experience at this hospital, who's to say that that's not going to be your experience at all other hospitals?" So it's never even really crosses your mind to go somewhere else for care because it's already not being handled at this one place. That leads to people neglecting their health, which can sometimes be generational. And another participant said, "People don't know about the help because they ain't asking for it." They hit on in the intake questionnaire, "Yes, I got food to last until next month. when they really probably don't, because they'll probably think they're going to take the kids or something when they're really just trying to help. Theme 5, diversified care teams can improve care delivery. Participants noted a lack of congruence in social identities between families and those working within healthcare and social service systems can lead to lack of trust or strains on the provider, patient, or client relationship. One participant noted bringing in that extra person, in this case, a community health worker, who brings in an element of diversity and who has knowledge about these things that the family might be struggling with. It gives them a sense of hope, like, oh, okay, somebody sees me, somebody cares. And finally, theme 6, optimal care delivery requires empathy, clear communication, and partnership. Participants were acutely aware of the power that medical providers hold. They recommended doctors build trust by practicing empathy, which included listening to concerns, explaining findings and recommendations in detail, and meeting patients' needs. One participant noted, I appreciated the way the doctor took the time to really empathize with me and understand where I was in my life, how this could be affecting me, and how this news can make me feel. She took the time to really put herself in my shoes. And finally, a participant shared, a good experience means that I'm getting treated like a human and not a number or statistic. I am treated like a human, like I matter, like my experiences matter, my voice matters, and I'm not just a needy person with my hand out. The third step in the roadmap is focused on effectiveness. And in this stage, we aim to develop or optimize or assess innovations. This step may involve leveraging several types of study designs, including quality improvement or implementation science or quasi-experimental design. These strategies may be leveraged particularly when other methods like randomization are not feasible or ethical. And so this is one quality improvement initiative that we did at Cincinnati, which was focused on, this is actually a study that my colleagues did at Cincinnati to assess the impact of a medical legal partnership. So it was a retrospective cohort study examining the effect of referring patients to a medical legal partnership on hospitalization rates among urban low-income children in Greater Cincinnati over a 5-year period. It compared over 2,000 children referred to a pediatric primary care-based medical legal partnership with 100 randomly selected control cohorts drawn from over 34,000 children seen concurrently at the same pediatric primary care clinic, but not referred to legal aid. And here, just to orient you to this figure, on the x-axis, you have childhood hospitalization rates for both the intervention and control groups prior to referral to the medical legal partnership. And you can see the difference for the intervention group after referral. Essentially, median predicted hospitalization rates for children in the year after referral was nearly 38% lower if children received the legal intervention compared to the control cohort. And then this is a quality improvement study that we did, really focusing on trying to reduce caregiver hunger for children, for caregivers of their kids while they were admitted to the hospital. So this QI project took place at a 41-bed inpatient unit, and our primary outcome of measure was caregiver reported hunger. We essentially asked caregivers near the time of discharge if they experienced hunger at any point during their child's hospitalization. We did several plan, do, study, act cycles and addressed several key drivers, including awareness of how to obtain food, safe environments for families to seek help, and access to affordable food. This is our Pareto chart, and essentially we were able to categorize the reasons caregivers told us they went hungry during their child's hospitalization. And the category that stood out the most to us was that the food in our cafeteria was too expensive. And you can see the other categories based on what caregivers shared with us. This is our statistical process control chart. On the x-axis is time by week. On the y-axis is the percentage of parents or caregivers who reported hunger over their child's stay. You can see that the rate of hunger was nearly 90% at the start of this project, and most profound in our patients and families insured by Medicaid. I won't go through all the interventions, but I do want to draw your attention to this one. We did a temporary test of change where we gave 2 meal vouchers per caregiver per day over the course of their child's hospitalization. That resulted in special cause decrease in the percent of caregivers reporting hunger. Then COVID struck and we had to stop data collection for several months, but it allowed us to garner support from our senior leaders at the hospital and secure permanent hospital funding to continue to give caregivers 2 meal vouchers per caregiver per day. And you can see the rates of caregiver reported hunger decreased substantially after that intervention. And finally, the last step in the roadmap is focused on impact. And this is where we scale and spread innovations for maximal impact. And this is where the power of learning networks really come at play. Like elsewhere on the roadmap, inclusivity of the right experts and the partners in learning networks are really critical to the success of the work. So just to talk about learning networks or just defining a learning health system, a learning health system is where we bring internal data and experiences and integrate that with external evidence and try and put that knowledge into practice. It helps facilitate a continuous cycle of learning, application, and feedback where we're able to generate and apply the best evidence, drive discovery as a national outgrowth of care, and facilitate innovation, quality, safety, and value. When we think about equity-oriented learning health systems, these are some of the principles that we applied. We wanted to make sure we had shared purpose, that we had a clear definition of our population of interest, that we were very clear about our denominator and numerator for measurement, that we segmented our data to identify equity gaps, that we devised theory and clear key drivers to promote the work, that we identified our scalable unit and scale plan, and that we facilitated formal testing and learning. So I'll talk through 2 learning networks that we were able to establish at Cincinnati Children's, the Health Equity Network and our Asthma Learning Health System. So just a little bit about the Health Equity Network. Our shared purpose was reducing inequities in child health outcomes, and our population of interest was Cincinnati youth, and really trying to address the disparity in our hospitalization outcome. Our denominator was all youth, and our numerator were those who were hospitalized. We were able to segment our data by race, payer, and neighborhood. We co-produced key drivers, and then we considered our scalable unit, which was our clinical sites as well as our neighborhoods. And then we created a learning network to really try and formalize testing and learning. So this is a time series chart illustrating our total admissions per 100,000 youth 20 years of age or younger in the 8 Southwest Ohio County region. So on the x-axis, you have time by year. On the y-axis, you have the hospitalization rate. This is looking at the same data, but the data is segmented by race, with the orange line indicative of the hospitalization rate for Black youth, the blue line indicative of the hospitalization rate for all other youth. And you can see the notable equity gap there. We further segmented this data to see if the equity gap still persisted when we looked at specifically physical health admissions and mental health admissions. And you can see the equity gap still persisted between Black patients and all other patients. And as a result, we launched this Health Equity Network with the global aim of trying to achieve excellent and equitable health outcomes. We wanted to decrease the gap we saw in total hospitalizations between Black youth and all other youth. And we had very key process indicators, as you see here on the chart. We had several teams in our Health Equity Network, teams that were working on various patient populations and conditions. And even though they were different in terms of their patient population of focus, we knew that the drivers of equity gaps were all likely the same. And so there was a real opportunity to bring people together to learn. So this is our key driver diagram. Again, our global aim was zero gap in child health outcomes by race and socioeconomic status. Our SMART aim was decreasing the gap in total hospitalizations by race. And you can see the population was our youth in our 8 Southwest Ohio county region. Our primary key drivers included access. In other words, how could we ensure we were able to provide the right care at the right time, in the right place, and in the right way? How could we meet needs and address social and structural determinants of health? How could we build strong connections, essentially effective and seamless links across the health system and between health and community systems? How could we build trusted relationships where partners were welcome, heard, and a part of the work? And finally, how could we cultivate an environment that we can learn by doing and fortify a learning network aligned with institutional and community priorities and bolstered by a culture of equity? These are the 10 action teams that we had in our health equity network, and you can see the diversity of the teams as well as their specific SMART aims that rolled up to our larger goal. And then this is the way we organized ourselves within this health equity network. We had a core team that was led by Dr. Beck and myself. We had core quality improvement, data analytic, project management, and community engagement support. And then we outfitted each team with similar support. So every team had a team lead, they had a quality improvement person, a data analytic person, as well as access to community engagement and subject matter expertise. We brought teams together twice a month. Once a month, we had an action period call where teams would share what they were testing, what they learned, what were the successes and barriers, and what were their plans for testing for the next 30 days. We also had a monthly solutions lab where we would bring in subject matter experts and they would focus on one or more of our system key drivers, taking a deep dive and finding ways for us to think about what were potential interventions that we could test within the network. This was one of our key process measures for the entire network. We knew that the impact of the medical legal partnership in our primary care clinics was profound, and we wanted to scale such that our subspecialty clinics had access to identifying and referring patients for a medical to our medical legal partnership. And so this was one of the main process measures that we scaled within the health equity network. And you can see over time, referrals from our teams to legal aid increased over time. And now I'll share a few of the successes of some of our health equity network teams. This is our asthma team, which was focused on 322 patients co-managed by primary care and our pulmonary medicine colleagues. These patients were mostly Black or African American. Many of them were insured by Medicaid, at least 85%, and many of them had moderate to severe asthma. And you can see the rates of hospitalizations related to asthma. There was a large gap between our Black patient population and all other patients. And this team did a lot of work to narrow that gap. This included embedding social needs screening within their clinic, identifying patients to refer to legal aid, referring patients to our health department to address environmental concerns in the home, connecting patients to community health workers. We were able to hire a couple of community health workers as a part of our Medicaid Accountable Care organization to support our asthma patients. This is one of our adolescent medicine teams that was a part of the network, and they were focused on reducing admissions for their patient population, specifically for mental health related conditions. Patients seen at the Teen Health Center were primarily insured by Medicaid and primarily Black or African American. And again, they were able to embed health-related social needs screening within their clinic, able to connect families to care managers and social workers. They embedded processes for follow-up to mitigate any challenges with medication adherence and refill issues. And as you can see over time, they started to decrease their rates of mental health related admissions. Here are some other improvements of teams. We had a type 1 diabetes team as a part of the network, and they noticed a significant gap in rates of type 1 diabetes related hospitalizations between Black patients as well as publicly insured patients. And they identified that there was inequity in CGM and insulin pump usage. And so they focused on equitable deployment of CGM and insulin pumps. And you can see here, they made tremendous improvements in ensuring that Black patients had access to CGM for their type 1 diabetes. We had a peri-op team as a part of our network, and they noticed that their patient populations had higher rates of preventable cancellations of procedures. They started doing health-related social needs screening and identified transportation as a significant barrier for particular patients, and were able to garner funds such that we could provide transportation vouchers for families such that they could get to their procedures, and they started to see signal of decreases in preventable cancellation rates. And finally, this is our sickle cell disease team that wanted to decrease rates of missed appointments as a way of decreasing rates of hospitalization among their patient population. Again, we were able to partner with our Medicaid Accountable Care Organization and have more community health worker support for this particular patient population. And then this is a screenshot of the dashboard that we were building as a part of the network. You can see the ways in which we were able to disaggregate the data for hospitalizations. You can see total admission rates. You can see the data disaggregated by physical and mental health admissions. We were able to disaggregate the data by race and ethnicity, as well as acute versus chronic reasons for admissions, and look at the admission rates by one or more counties in the region. And then this is just showing the overall narrowing of the gap of total admissions as the network expanded. We started off with 4 teams, we expanded to 10. This year we expanded to 17, and next year it'll be 25. So the goal is to really try and engage as many teams as possible in this work. And as we continue to add, the theory is that this gap will continue to narrow. So just a little bit about our asthma learning health system. Again, a lot of the same strategies apply here, where we really wanted to reduce disparities in asthma outcomes, particularly asthma hospitalizations among our patient population. Asthma in particular is really challenging. It is a very complex and costly diagnosis, and we know that inequities in asthma morbidity are profound. And unlike other chronic pediatric diseases like type 1 diabetes, asthma management is really hard in that the care is fragmented. Who is designated as the primary asthma home can vary from a primary pediatrician to an allergist to a pulmonologist. And so the silos within healthcare systems exacerbated the fractured care children with asthma receive. And so we asked ourselves, what would it take to achieve a reduction in the Hamilton County asthma admission rate such that it was 10% better than the national average? Hamilton County is the county where Cincinnati children sit. The national average for asthma-related hospitalizations is about 88 per 100,000. And you can see that across all of our segmented data, that the rates of asthma admissions far exceeded the national average, where the rate in Hamilton County was nearly 263 per 100,000. The rate of one of the neighborhoods in Cincinnati, Avondale, which is the neighborhood where Cincinnati children sit, was nearly 560 per 100,000. You can see the rate for the 10 disadvantaged neighborhoods in Cincinnati, and you can see the rate of asthma-related hospitalizations for Black patients and all other patients, all above the national average. And so we did some back of the envelope calculations and said, if we wanted to get to 10% lower than the national average, this is what it was going to take. These were the absolute numbers that we would need to decrease on a yearly basis to get there. And so our SMART aim for this particular learning network was twofold. We wanted to decrease the annual number of asthma admissions for children in the neighborhood of Avondale. We wanted to do some targeted work in that neighborhood from 24 to 12. And we wanted to build towards decreasing asthma hospitalization rates to our goal of 80 per 100,000 per year. We knew that that was a years-long goal, but we wanted to set an aspirational goal to get us there. Our primary drivers were excellent, equitable, and evidence-based acute asthma care, excellent, equitable, and evidence-based preventive asthma care, health-promoting homes and neighborhoods, coordinated accountability and action within the healthcare system, and effective and seamless connections between healthcare, community partners, and households. We also prioritized intervention categories that we thought would be necessary to advance the work. We really wanted to focus on interventions related to access to medications, reducing exposures and triggers, and building strong connections. Here are some examples of those interventions that fall within those three categories. As it relates to access to medications, we wanted to focus on providing evidence-based meds, making sure kids had meds in hand prior to discharge from the hospital, think about the ways in which we could enhance med delivery to homes and schools, and partnering with schools such that kids could actually get their meds administered at school. In terms of reduction in exposures and triggers, this was leaning on our partnership with the health department and our legal aid society, and thinking about how we could distribute HEPA filters, pillowcases, and other things that would help with triggers. And finally, connections was all focused on building connections with key partners, including schools, legal aid, and the health department, connections between primary care and subspecialty care, thinking about how we could enhance asthma-related home health visits, thinking about community health worker engagement and care management, and then connecting with our asthma navigator that was part of the Health Equity Center. We had several teams in the learning network, including external partners, health department, school-based health centers. We had several primary care clinics that were not affiliated with Cincinnati Children's as a part of this network, because this was a population-based endeavor, and we knew we couldn't do it in and of ourselves. And then these are some screenshots of the dashboard that we built. So we wanted to be able to disaggregate the data by neighborhood. So here you could filter information by neighborhood, you could filter information by race or payer, you could filter information by where they were getting their primary asthma care from, whether that was through Gen Peds or through our pulmonary colleagues. And then as you filtered at the bottom, you would get patient level information that then you could do targeted outreach. We also wanted to create a way to identify patients who were at significant risk of hospitalization. So we built this as a part of our dashboard where we were able to create a patient prioritization tool. So we said, what are the things that would lead to increased hospitalization risk? Previous ICU stays, emergency department visits, positive screens for health-related social needs, steroid use within the first year. And then you could still filter by neighborhood, race, insurance, and then whether or not they were seen by POM or seen by our Gen Peds colleagues. And then as a result of that filtering, it would generate a list of patients that then you could do targeted outreach. And so we were training our care managers and community health workers to use this tool to identify patients at risk so we could do proactive outreach. And then finally, one of the things we instituted was a weekly asthma action huddle. And the goal was to really promote situational awareness and drive action to improve asthma outcomes. So we had a weekly call every Wednesday with a multidisciplinary team. It included physicians, nurses, asthma coordinators, care managers, social workers, community health workers, as well as our QI and data supports. We would review patients with asthma admissions over the past several days. So I would go in, I would review the asthma admissions, we would talk about patients, and we would come up with plans for outreach or addressing any issues that we noted on our chart review. And then we leveraged the huddle to really try and learn about what was required to coordinate interventions at scale. And so I want to close by just highlighting a roadmap towards action. I think that was really the intent of walking through this, right? It's important to build the evidence base. It's important to think about how we can unleash motivation, insight, and expertise of partners and leverage co-production. It's also important for us to think about how we can actually generate common objectives to build will and ensure that we have shared purpose. Data is key, and so thinking about the ways in which we can promote integrated data streams. We want to make sure we're able to build inclusive coalitions for rapid learning and action. We want to make sure we create space for rapid, iterative prototyping to adapt and scale. And most importantly, we want to make sure we amplify the lived experiences of our patients, families, and community partners. So I'll end with this quote that I love, that I think really underscores the importance of this work. The inequities in healthcare that existed at the turn of this century have persisted or worsened. We know why. Decisions made about what to improve and how to improve without first asking crucial questions such as who benefits or who gets left behind only preserve and cement inequities. Designing quality initiatives for certain populations rather than with the people most affected will lead to less improvement, less sustainability, less trust, and less equity. And then I would be remiss if I did not thank all of the wonderful people who were involved in this work, particularly my friend and colleague, Andy Beck, Dr. Rob Kahn, and all of my wonderful mentors at Cincinnati Children's. And just want to emphasize how excited I am to be here and hopefully think about the ways we can implement similar things here at Stanford Medicine Children's Health. So with that, I thank you and I'm happy to answer any questions.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.